Hi, everybody. I'm Harrison Alter. I am at Highland Hospital in Oakland, California, and I'm the research director for the Andrew Levitt Center for Social Emergency Medicine, also in Oakland. Aimee Moulin had to respond to a family event this morning, so she's unable to join me. So you were promised a dog and pony show, and you end up with the dog. But we'll work it out. Oh, I forgot this. Dr. Moulin has nothing to disclose. I'm using my computer because it has her half of the presentation on it, which I haven't quite learned yet. I have to disclose that I have numerous relations in media, and so discussing the use of the mainstream media in advocacy in emergency medicine arises largely from the reporter's viewpoint. A little bit from my own experience relating to reporters, appearing a couple of times in electronic media and a couple of times in print. I don't have extensive experience there, but I did. So if this were a research abstract, the next slide would be my methods. My methods were qualitative interviews with 4 family members who are all reporters, and coded analysis, elaborating themes from those interviews. Basically, the take-home message is that you want to establish a relationship with the media that puts you on the other end of Walter Matthau's candlestick phone. They all still look like Walter Matthau, and they all still use candlestick phones. Actually, they don't. But the idea is that you want to establish a relationship of trust that makes you the person that they want to call. So we're going to kind of guide ourselves through this process of developing a relationship of trust with reporters using a set of rules or guidelines or whatever it is that we choose to ignore when we're practicing clinically. So the first and probably most important rule is when you get a call from a reporter, call them back, text them back, and do it fast. You don't have to talk to them right away, but in their mind, they have already figured out where you fit in the structure of the story that they want to write. And without that piece, they're just going to move on. So get back to them as quickly as you can. You know, put it off till whenever you can honestly have a conversation with them. And do it quickly. And in the interim, while you're finishing your shift or whatever, start to kind of think, if you can get the nugget of the story that they want to write, then think about how you'll respond to them in the afternoon. And if you can't, just say, I'll call you at 4 after my shift, and we'll have the conversation. Rule number 2 is just kind of a throwaway, because obviously we treat everyone courteously. But Megan's lessons about social media really apply here. I've talked to so many reporters who feel that on the basis of a single bad experience, that doctors are arrogant jerks, that you know, they don't take me seriously. I don't even really want to get assigned a story on the health sector because it means I'm going to have to interview a doctor. You know, a couple of generous, spirited acts can help to turn that around and develop a really good, enduring relationship with somebody who has the public's ear. I guess we didn't go back and start with fundamentals, which is, why does this matter, right? We talked about social media. We talked about testimony in Congress. Those are 2 very important mouthpieces, but conventional media still has most of the eyeballs. Social media has most of the sexy stuff, but conventional media, people still watch and read. So in terms of getting the message straight, and plus conventional media drives the conversation on Twitter. When Megan's talking about retweeting or sharing content, much of the content she's talking about sharing is stuff I saw on TV or stuff I saw in the New York Times. I post that into my Twitter feed, and so it gets amplified that way, but it started in conventional media. So treat them well, and they'll treat you well. So the relationship of trust with the reporter in question is a reciprocal thing. If you trust the reporter, they'll trust you back. The reporter is not playing gotcha. The reporter is there to learn. They're calling you because you're an expert. Now, on TV, you may get pressed pretty hard. They're not usually trying to humiliate you or corner you, unless you're a politician. They'll sometimes do that. They're trying to press you hard so that you don't hide behind your talking points. But it doesn't mean that the environment is not a learning environment. The relationship of trust really hinges on this idea of what constitutes background. So you have an initial conversation with a reporter, and you usually want to start out by saying that we're talking on background. Now, in Washington, D.C., there are all these different levels of background, and they all have their names. You know, there's background and deep background and not for attribution. Don't try to name it. Just describe what you're willing this to be. And what you want the first conversation to be is really strictly just informative. You don't want to be quoted as a physician on staff at ABEM General. You don't want to be quoted at all. And then in the context of the learning conversation, where you're kind of sketching out the lay of the land for the reporter, which you understand better than they do, thus prompting the call, you can say, if you need a quote, we can talk about that later. I can call you this afternoon with a quote after you've had time to reflect. But they'll be able to write their story without that quote. So they can get their project rolling just by understanding the story better. And you don't have to provide them with a quote right at that moment. Now, this came up in both the legislative testimony talk and in the social media talk. You have to position yourself in the way that you want to be considered. So, do you want to be interviewed as, you know, the research director at the Levitt Center for Social Emergency Medicine? Is that who you're speaking as? Are you speaking as an attending physician in the Highland Emergency Department? Or are you speaking as, you know, Dr. Alter, an emergency physician in Oakland, California? So usually you aren't speaking for your institution. You don't want to be speaking for your institution. They probably don't need you to be speaking for your institution. And you'll get in trouble if you speak for your institution. So just be yourself and speak as yourself, unless you're empowered to do otherwise. There's not a lot of text on this slide intentionally. Is anybody recording this? SAEM is recording this. Okay. So the Press Flack. Most of our hospitals have a media relations executive, a vice president for external communication. That person sends us emails reminding us that we're not to speak to a member of the press without running it through them and without them being present for the event. I got to say, reporters hate this. I've done this both ways. Sometimes this is better to ask forgiveness than permission kind of arrangement, although your job could be at risk. It's clearly written in our medical staff bylaws that unauthorized communication with the media is cause for dismissal. But you show up, the press flack is there, the reporter's there, you give some anodyne story about whatever they're curious about. You're looking over at the press flack every few minutes to assure that you're not overstepping. They go home, the reporter goes home, flips through the notebook, looks at their notes, and realizes that they have what reporters call dog shit, and they say, to hell with this, I'm going on to another story. This was a good idea, but I don't have any good sources, and nobody's going to talk to me. So whatever issue it is that you wanted to try to educate the reporter on, you've now flushed down the toilet, to mix metaphors, sort of. So yes, we have to adhere to this rule. Yes, we could be dismissed from our job for not heeding it. One colorful way I've heard of dealing with this, although quite deceitful, I have to say, is to schedule it by a three-way email, and then at the last minute to reschedule by a three-way email, and like 10 minutes from the time you're going to meet, and then say, oh, well, you were on the email for the reschedule. I'm sorry that you weren't able to show up. At 9 at night. Exactly, at 9 at night, right. In a covered parking structure outside the Watergate Hotel. So I'm not really, I feel like I'm sort of encouraging you to break the rules, but I want to say if you're going to break the rules, do it knowing the risks and the consequences. But the benefits are great. Again, people trust doctors with their lives. Hospitals should trust doctors to have an adult conversation with a reporter. That's the way the reporters feel about it. Okay. This is a little unflattering, but I didn't make it up. This actually came directly from a reporter. She said, talk to them as though they're in 5th grade. Now, this is only true if you actually treat kids with respect and don't talk down to them, which they hate anyway, right? But the general idea is the same as what Hanni said earlier about testimony in Congress. How many are attendings? So how many times have you walked by a curtained room and heard somebody say, well, when somebody comes in with your complaint, or when somebody presents as you do, or we think it's an organic process, these are words that have a meaning elsewhere in the world, right? Out in the real world, all of those words have a meaning, and it isn't the one that you're using at the bedside. And so you have to watch your language very carefully to make sure that you're not using terms that we think we know we mean, but that mean a completely other thing out in the real world, A. And B, we know what they mean only because we went to medical school for 4 or 5 years in my case, or residency for, umpteen years. We only know these words because we're the expert. They're talking to us because we're the expert, and we can interpret those words for their purposes. So No jargon, no clinical talk. There's no advantage to sounding grand round smart. You know, you only need to sound like you've thought through the problem and you know how to communicate it. And lastly, Zach Mazel talks about narrative medicine as being one of the most powerful and underutilized tools in advocacy. You know, everybody's talked about it today, the importance of patient stories, which puts me at a huge deficit because I can never remember a patient encounter from one day to the next. But the power of our bedside experience is really what transforms our opinions into something that people can relate to. Okay, so why are they calling you? They're calling you because you're the expert. They don't necessarily know the questions to ask. They know what they want to ask, but you know what's important because you're the expert. So in your answers, and this is especially true on television, it's like a good resident or medical student presentation. There's no room for suspense. Put the most important thing up front. Don't bury the lead. Just like what Liz said. Don't bury the lead. Don't put the diabetes in the third paragraph because it really mattered for the chief complaint, right? So say your most important point at the top. In your head, if you had time before the conversation, think of, or if you know the topic well, think of the 3 or 4, or Hanni said 2 or 3, whatever the number is, most important things that the person must walk away from the conversation and remember. They have to be able to find it in their notes. They have to know. I had a professor once in medical school. He was a urologist. And he said, you know, they told me that I'm not allowed to tell you what's on the test anymore. So let me tell you this. If I say something and stamp my foot 3 times, pay really close attention. And it worked. So tell the reporter what's going to be on the test, right? Make sure they leave there with the 3 or 4 points that you consider most important. Don't bury them in statistics. We've already talked about that. But use a couple judiciously to illustrate your point. And use the most colorful, simple statistics you can think of. Don't talk about odds ratios. Don't talk about hazard functions. Every time Megan Ranney is on television, you'll hear her say, 200 people are injured and another 100 killed with guns every day. You'll hear her say that every time. And it's memorable. It's, you know, it's encapsulated. It's discreet. And it's powerful. Keep in mind, anytime you open your mouth, that whatever you say has to satisfy 2 conditions. Why is this important? And why is this important now? Even when you're trying to do a 3-minute deep dive into the background that you think they need to know. How does this contribute, and why is it important to be done right now? Remember, they're already sold. They're doing the story. But they have to sell the story to their editor. So what's their editor going to ask? Why is this important, and why is this important now? So everything in their notebook, everything that goes into their story has to be able to answer those questions. So keep that in mind as you're speaking. Why is this important? And why is this important now? You want to help them sell it. The reporter asks you, Don't you think ERs need more education on prescribing opiates? What do you answer?
I guess it depends on what the point I wanted to share was. I would. This is really hard, guys.
I'm sorry.
No, it's fine.
I don't mean to put you on the spot.
I guess I would say that. Oh, thanks. Sorry. This will make it much less stressful. So what was the question again?
Don't you think ERs need more education on prescribing opiates?
Well, I'm not sure that education is the question here. I think the real question is that our patients need, and then I would say whatever my platform was.
Excellent.
Okay.
That's the back up and back out. Okay. So acknowledging their question, stepping back, and going the way you want to go, right? You may have some success by acknowledging the question without diminishing it. So sometimes you can say things like, medical education is important to providing good care. That's why we think that board certification and residency training are important. But opioids, right? The shift and pivot is a slightly different construct, which is another way of moving back to your point. Anybody have a good sense of a shift and pivot for that question that I asked Shannon? Don't you think ERs need more training and education on prescribing opiates? Dennis has one. Here.
I guess I could try saying something like, yes, it's always good to get more education on things like opiates, which are very dangerous. However, I think a lot of the issue is around XYZ.
Here.
You could say, like, I agree that education about opioids is important, which is why we're doing so much work around opioid addiction and how to effectively treat that in the ER.
Good. Anyone else want to? Yeah.
But most ER doctors have at least 8 years, sometimes 12 years of education under their belts, but they're up against X, Y, and Z problems that you would want to discuss.
Yeah. Let's say that, Jay?
We know there are barriers to appropriate prescribing, but what we've identified is access to the PDMP as the biggest barrier for emergency physicians.
Also a good approach. Maria?
Might as well continue the trend. Well, it's an interesting point, and you may not realize that emergency physicians are actually responsible for a very, very tiny fraction of opioid prescribing among all physician specialties.
Yeah. Yeah, you could say that in 3 words and be done with the education piece and then be moving on to the piece you wanted to get to, right? You could say, oh, emergency physicians write for very short-term prescriptions, but what we really care about is access to primary care to bridge them to treatment, once they're out of our care. Or what we really care about is, community involvement around naloxone training to prevent them from overdosing once they're out of the emergency department. We just write for a couple days of prescriptions, but here's I like the way Amy put it here. Answer the question you wish you were asked. So you can acknowledge their question, dispense with it as quickly as you can without going down their rabbit hole, and then answer the question that you wanted to be asked, which was about community response or access to primary care or whatever. Lastly, and this is the end, make sure you did your job. So they called you because you're the expert, you want some of that expertise to rub off on the reporter, because the reporter is going to get asked at a dinner party about this issue, and they want to be the expert, right? So, of course, they also want to write an article or, have a thing on the morning news about it, but really they want to feel like they have a good grasp of this issue, and they have the same grasp that you have. That's what you want. So, after you're all done, ask them, have I done my job? Is there anything about this that I can clarify more or add detail to, or, stuff where I use, clinical language that could be better explained? And they'll be grateful to you. Yeah? Yeah, let's... Okay.
How do you address it if they misquote you or they paraphrase you incorrectly?
Yeah, there's no winning. Yeah.
I actually sometimes, I don't have done a lot of this, but I will ask for them to send a transcript or send me like a summary email, and then I will actually make edits.
Yeah, they won't usually send you the article. That kind of violates their internal code. I haven't thought of asking them to send you a summary.
The problem is sometimes it's like the story needs to be printed that day or that night. You don't get that liberty, so then you just have to be really, really clear.
Yeah. There's no value in trying to chase them down or, tweet about it and say you've been misquoted. And, one approach I've seen done, I've never faced this situation myself. One approach I've seen done is that somebody will tweet the story, say it's a great story, the reporter brought to light all this fantastic stuff. I wish that they had been more accurate in quoting me. What I really meant to say was, yeah, no, it's a. I mean, if it's a factual error, that might warrant a letter to the editor. If it's a question of feeling misquoted, or that your quote was taken out of context, that's something you just got to wait for the next news cycle to wash it away, and it will.
You might give a reporter like gold in terms of from your perspective, in terms of what you told them, and they will choose the tiniest little soundbite and publish that, and you'll be like, that did not encapsulate what I was thinking at all. Nothing. And then I feel like an idiot.
Yeah, but you don't necessarily look like an idiot.
Yeah, I mean, they're using you to fill in their story, right? It's not a platform for you necessarily. You can ask for a platform, but
yeah, that's more the Liz Samuels thing. If you want to get out there exactly what you want to say, that's an op-ed. You're being a source for a story is not that at all. It is an opportunity to reframe questions, and quite frequently, I'll get a call about ED overuse or something like that, or inappropriate emergency department use. That's a great opportunity to reframe a question and to kind of blow a reporter's mind, really, because they haven't thought about ED overuse as being, a social issue. They think of it as, like half of our colleagues do, abuse of the system, right? But it is a great opportunity to reframe a question.
So I had an experience where some of my work has
in the past has been sensationalized, and that was partially my misapproach to the topic. But also, you don't have control over, what people end up writing, and it was very challenging. And yes, at some point you get over that, but I think for me, there was a lot of just learning points from the experience, and just being very, sticking to your points, being sort of very repetitive. That's some of the things that Harrison mentioned earlier. And then also choosing more wisely about what to advocate for, and really making it like your topic of interest and your passion, and sort of sticking to that, because those are the things that sort of the closest, and that you can feel good about. If someone calls Harrison about unnecessary ED visits, there's a very clear message that I've heard him and Maria and others sort of highlight, and sort of staying on point with your own passion and topic too. Yeah. But
that's a great point. Has anybody else had an experience being misquoted or misrepresented in the media? How are we doing on time, Dennis? Okay.
I mean, I was quoted, and they got a statistic a little bit off from what I had tried to convey, and just decided it wasn't worth kind of the hubbub of trying to correct it, that it was, in an academic setting would have been important, but in this setting was close enough to the point. I guess one question I had for you is whether you screen engaging with a reporter at all, in terms of if somebody comes to you and you can kind of tell that the story is already pre-written a certain way, and that whatever you say is going to get plugged into a certain spot, if there are requests that you turn down, or
Absolutely.
how you respond to that in a respectful way, where you keep that relationship open, but without getting pulled into something you don't want to be in.
Yeah, it's not really my area. I have 3 shifts coming up. I'm not really going to have a minute to do this before your deadline. Yeah, I mean, again, be courteous, be prompt. Rule 1 and Rule 2 still apply, but you're under no obligation to do it, and it actually will serve you ill if you try to reach beyond what you're expert at, and or if you feel like you're going to get painted into a corner.
Can you ask for pre-clearance of quotes like this? That's a...
You can ask, but they're usually going to say no. Yeah. Uh-huh.
That kind of stuff.
That's smart.
Yeah.
And then they want to be there with you.
Sometimes. It depends.
Yeah. Yeah, that's smart.
They'll usually be like, yeah, I've worked with them before. This might, there was one recently where I was like, is this a good media source? And she was like, actually, this is a good writer. And she's just switched over to this, publication, and I think it'll be good. So.
Yeah. It's like on Veep where he says he's from BuzzFeed print edition. All right. Thanks very much, you guys. Oh, yeah, Jay? One quick point.
A question. What about reaching out to the media, particularly, so you've got an article coming out. You work with media relations. They put out a press release. What do you think about, as the physician or content expert, reaching out to people you don't have an existing relationship with?
Oh, that's tough. That's going to be a fishing expedition. That's partly why you want to cultivate a trusting relationship with a reporter or two, because then when you have something you want to pitch, you have somebody to go to. I think cold pitching it usually ends up the same as press releases. You may get lucky. Usually, if you look through LinkedIn, you'll find at least a 2nd or 3rd degree relationship with somebody in the media, and you can use that to directly contact somebody. But, if you put in your subject line, referred by Jay Schuur, here's a paper I have coming out that's in your area, you've written on it several times, I noticed, in a thoughtful way, you might be interested in it. Jay told me that I might be able to contact you through this email account. I'm happy to engage with you if you want to cover this paper coming out. on Thursday. That's a great way to do it. All right.